morning, everyone. My name is Gautam Sharma. I'm one of the research fellows working in the Department of General Surgery. Uh, First of all, I'd like to thank SAGES for giving us the opportunity to present our work, and my mentor, Dr. Crow, for being supportive throughout my work. So, to starting off with our work on the outcomes of concomitant ventral hernia repair during bariatric surgery. To start off with the disclosure, here are some of the disclosure slides. None of them are relevant to our study. With a brief background, the incidence of ventral hernias in the obese population reported has been 8% by Datta et al. And the implicated contributory factors are the high intra-abdominal pressures, secondary to visceral fat, and weight-related comorbidities like the diabetes and impaired wound healing, and suboptimal facial approximation due to thick subcutaneous tissue. Currently, there is no consensus on the timing and management of ventral hernias in patients undergoing bariatric surgery. So what are the factors responsible for the controversy? It's the longer operative time, complexity of the combined procedure, and the risk of mesh infection in a clean contaminated case. So one group of surgeons definitely favor performing a staged repair, and they argue that the lower risk of recurrence and the complications after weight loss and resolution of comorbidities with the less technically challenging procedure is a better option. But on the downside, we definitely have certain disadvantages, like the risk of early postoperative small bowel obstruction, the risk of anastomotic disruption, and the increased cost and impact of two different procedures on a patient. So with this thought process, we wanted to evaluate the outcomes and the incidence of concomitant ventral hernia repair during bariatric surgery. The primary endpoint of the study were defined as the incidence of hernia recurrence and mesh infection, and the secondary endpoints were the perioperative morbidity. We collected data from an IRB-approved, prospectively maintained database of the primary bariatric procedures from 2004 to 15, with an inclusion criteria of primary bariatric procedures performed with concomitant ventral hernia repair. All the revisional bariatric procedures were not considered. Data was collected on baseline patient demographics, perioperative information, bariatric surgery performed, and the technique of ventral hernia repair, postoperative complications that were early and late, and the hernia recurrence rate. So coming to the results, so from 11,498 patients that received primary bariatric procedures during the study period, 159 were eligible for the study. And the median age for the study group was 53 years, with a preoperative BMI of 48.2. To note, these patients had significant comorbidities associated as well, with certain group of patients having a past surgical history of hernia repair, being 41, and the other abdominal surgeries being 75. We classified the patients according to ventral hernia working group classification for surgical site occurrences, being 96% of the patients coming under grade 2. Among the types of bariatric procedure performed, most of the patients received Roux-en-Y gastric bypass, that is 105, followed by sleeve gastrectomy among 50, and lap adjustable gastric banding among 4. For the approach used, 144 were laparoscopic, followed by 12 being conversions and 3 being open procedures. It is important to note that the type of ventral hernia repair was primary in 115 patients and mesh in 44. Coming to the post-operative complications, among the early complications, 10% patients developed the early complications, while 26% patients had late complications. This was further divided into major and minor complications, with 4 patients, that is 3%, having early major complications. Of these, 2 were hernia recurrence, and 4 patients received reoperations. This included 2 patients with hernia recurrence, and 2 patients had reoperations for reasons other than hernia recurrence, including possible sepsis and wound debridement for wound infection. 5 patients had readmissions. Among the minor complications, 10% patients had early minor complications. So we estimated the yearly cumulative incidence of hernia recurrence among our study cohort. It is to be noted that it is the total study cohort, including the primary and the mesh repair. Till 1 year, it was 17.7%, and after that, it almost steeply rose to 30.9%, and after that, it kind of plateaued to 32.2. This is a graph depicting the same. We further wanted to analyze the hernia recurrence rate among the primary and the mesh repairs. It can be noted here that the primary repair, the cumulative incidence was in the first year was 0 at 0 time and at 2.6% among the 30 days. And this accounted for the early recurrences among the patients. And at 1 year, it was 18.3%. Among the mesh repairs, this was comparatively less initially, that is 0% in the first couple of months, followed by 16% at 1 year, and then coming to 31.3%. So this is one of the largest single institutional studies reporting the outcomes of ventral hernia repair with bariatric surgery performed. So the hernia recurrence rate when comparing the primary versus mesh, and I must mention here, it's not like we're comparing apples with apples, it's more like apples with oranges. But it was interesting to note that early on the mesh repair had less hernia recurrence rate, but later on it was more or so very much equivalent. And I think it can be implicated because of the fact that most of the mesh repairs had very big hernia sizes, big hernia size defects. The recurrence rates, although comparatively a little higher, were comparable to the ones reported in the literature, like the ones with Eid et al. At 30-month period. The mesh infection rates were comparatively less, that is 1% in the late postoperative period when compared to the ones in literature. Of note, by recently published literature by Carbonell et al., who concluded that the mesh infection and the hernia recurrence rates were favorable, especially in terms of the synthetic mesh used in a contaminated ventral hernia repair. I think this is what it seems like going forward, that the type of meshes used would be helpful. Among the limitations, this was a retrospective study. There was no standardization on the type and the technique of repair, and there was a wide disparity on the complexity of the hernia repaired, especially with the umbilicals compared to in the incisional hernias. In conclusion, I would like to say the concomitant ventral hernia repair is safe and feasible, and there certainly the data is evolving with the use of synthetic mesh in a clean contaminated case. Thank you.